This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app.
Today's podcast is on lumbar artificial disc replacements versus fusions. The lumbar spine is your lower back. So we'll talk about what are the reasons to do either surgery, what are the good and bad things about fusions, what are the good and bad about the artificial disc replacements. We'll compare the studies from both, and then I'll tell you a bit about my preference and how I choose what to put in my patients. So we'll start out with what are the reasons for the surgery. And so people have back pain, and it's discogenic back pain, which means the back pain is coming from the disc, which is 80% of most people's pain, because that's where 80% of all the biomechanical activity occurs, is the disc. Now, you also have two facet joints, and you have nerves coming out, and muscles and tendons, and SI joints and hips, and all sorts of reasons that can also cause the low back pain. But the disc is the primary reason, and if somebody really has discogenic pain coming from the disc, then an artificial disc or a fusion are both viable options. Now, this is assuming they failed conservative management, done our Back Doctor app, done all the rehab, diet, meditation, massage, cardio, everything. It hasn't worked for 6 months to a year, sometimes even longer. It may be worth having surgery. And overall, the results of the surgery, people's pain goes from around an 8 out of 10 to a 3 out of 10. So it can really help people, but there's risks. Both of these surgeries are major reconstructive surgeries. You're taking the whole disc out, replacing it with an implant, metal, plastic, some type of artificial device. So you better be sure it's the right thing to do. So a fusion is the gold standard, and the fusion basically works because if you have this painful disc, we take the disc out, replace it with bone, put in some screws and rods, stop the motion, bone grows across the disc space, it never moves again, the disc never hurts again because it hurts when it moves, and that will treat the pain. But it sounds kind of barbaric, doesn't it? Because this thing's supposed to move and you're stopping the motion. So what's the downside is, if you stop the motion of that disc, it can put more stress on the discs on either side and increase the natural wear and tear of those other levels and lead to degeneration of those other levels. Then they have to have surgery. So what's the chance that's going to happen? Overall, it's around 25% within 10 years. Beyond that, we don't really know. But 25%, it's not a majority like most people think, but 25% is a legit number. That's 1 in 4, and we do a lot of surgeries, and so all over the country. And so that's a lot of people who are going to develop issues. Now, they might develop issues anyway because that's the nature of aging. And why did degeneration happen in the first disc in the first place? Well, that's aging. Well, you can get degeneration in the next disc too. But doing a fusion, we know, decreases the motion, which can put more biomechanical stress on the next disc, and it can lead to wear and tear to those at about 25% in around 10 years. Now, half of that 25%, the surgery they need is just a decompression, just a microscopic, make a little more room for the nerves. But the other half need another fusion, and that's what we want to avoid. So the benefit of the artificial disc replacement is that it preserves motion. It's still typically metal and metal, maybe some plastic in the middle, or different. There's a million different types of devices and materials. But the point is, make it stable and make it get rid of the pain from the disc because you're taking the whole disc out and replacing it with this implant that preserves motion. So hopefully it puts less stress on the other levels. But one of the things right off the bat is everybody's spine is different. Some are big, some are little, some are tilted, some have bigger discs, different angled facet joints. So you're going to put one disc replacement, one type of implant into a person, and the same implant into every type of person. Well, it's not going to reproduce the normal biomechanics of that disc in everybody. It can't. Everybody moves a little bit differently. So right there, it's going to tell you, okay, we may have a little bit of a mismatch problem here. And the thing with the artificial disc is that you can still have facet joint pain. So for every disc in the front, you have 2 facet joints in the back. That's why the spine's so complicated. It's a 3-joint complex. It's not like a knee or a hip. Those guys got it easy. Spines are complicated. Disc, 2 facet joints, and nerves coming out. So the artificial disc will treat the disc, but it doesn't treat the facet joints, and they may still hurt. They may still have arthritis and be painful. They may hurt after the artificial disc because you've changed the biomechanics of the facet joints. And then the second issue is the nerves coming out. You may get nerve irritability. And because of the preservation of motion, you can still get bone spurs, which can push on the nerves and cause pain and cause problems. So the artificial discs sound great. When they first came out 15, 18 years ago, I trained in England for a year, traveled all over the world and watched different surgeons do artificial discs. And when we came out, my dad and his partner, Litton Williams, were part of the FDA trials in America for the first 2 artificial disc replacements. So we've been in this from the get-go. And they sounded great. We all thought they were going to take over fusions. But guess what happened? One, insurance companies didn't want to pay for them. Number 2 is that we saw some complications. The results were pretty similar to the fusions, but the problem is if people get facet joint pain or nerve pain, they're really hard to evaluate. It's hard to know, is the artificial disc working, doing the job properly, or should you fix it? Because if you get an 80 to 85% success, so 80 to 85% of people get significant reduction in pain, are really happy. Well, that's a great surgery. Yeah, true. But guess what? 15 to 20% are still having pain, and a good amount of pain. So how do you evaluate those and know is there an issue? With a fusion, it's straightforward. For the most part, you get a CT scan, get a bone scan, evaluate him, take bending x-rays, see is the thing moving or not. If it's solidly fused and there's bridging bone across there, the surgery's over. There's nothing left to do. Maybe somebody still has pain, but at least you have an endpoint in your decision making, and you can look that person in the eye and say, you know what, I'm sorry, you're still having pain, but there's nothing else to do. Don't have more surgery. It's not going to help. You're fused. It's done. We got to look at the next levels, but if they look normal, well, then you're done. Artificial disc replacements, the problem is if somebody still has pain, we don't know how to really evaluate what's causing the pain and should we change them to a fusion. And the problem is when we go in to put the artificial disc in the first time, the blood vessels move. We go in from the front. The blood vessels move out of the way. Your aorta, your inferior vena cava, your intestines, everything. It moves out of the way pretty easily the first time. But after you've had surgery, then they scar down to the front. Going back in a second time, trying to move those things, they can tear. People have died. So it's a life-threatening revision surgery for the artificial disc replacement. And so if you fall into this 15 to 20% of having issues, it's really hard to evaluate. And that's where every surgeon's different. And I can just tell you for me, and every surgeon, hates complications and lives with their patients' complications. And it's the hardest part of our job is we know a certain percent of people are still going to have pain. And we lose sleep over it, and it weighs on us. The next time we're going to do surgery on somebody else and make a decision for them, we think about that last patient. This person's still in pain. We don't want this other person to end up like that too. And the artificial disc replacements, we shied away from doing them a decent amount because when people had complications, they were so hard to evaluate and to know what to tell this person what is to do for what's best for their life, that a fusion is a much more black and white answer. That we've gone, and most of the whole country and even the world has gone back to doing more fusions than artificial discs. And I think that's a fundamental reason why. So what does the study say comparing these two different techniques? And we've got a good amount of data out there so far. Part of the problem is you're comparing apples to oranges. Not all the surgeries are done the same. So the fusions we do now for a very similar condition, a painful disc, we'll go in from the front, same approach, and we'll do an ALIF. And going from the front, take the disc out, put a plastic spacer in with a little bit of coating on it, 2 screws up, 2 screws down, some protein to stimulate bone growth, and it's got a great success. It's a very similar surgery to the artificial disc replacement. Recovery is the same, time in the hospital. The only thing difference is you got to wait 3 to 6 months for bone to grow to get really solid. Whereas with the artificial disc, you only have to wait about 2 to 3 months to really know you've got some bony ingrowth and they're stable. So you got to slow somebody's return back to all their real exercise and big activities by 6 to 8 weeks. Maybe 6 to 12 weeks, but not that much of a difference. And so some of the early studies of fusions were old school fusions. They were like front and back, take bone graft, take somebody's pelvic bone, which hurts like hell. And so what the studies have shown is that artificial disc replacements, the patients have better satisfaction and they're happier. Well, part of the problem with that is because if you tell a patient, look, you're going to either get the artificial disc, this new great device, or you're going to get a fusion, which we've been doing for 50 years and it sounds barbaric. So then somebody wakes up and you tell them, it was a research study, you tell them, oh, by the way, you got the fusion, they're going to be depressed. You tell them you got the artificial disc, they're going to be happy. So patient satisfaction, a lot of that's going to depend on what you told them they got and what are their expectations. And that's part of that placebo effect, which we know is like 30%. Can affect results. And so that's a big deal. But the studies have shown artificial disc replacements return to work faster and get a faster improvement into function. And part of that is the preservation of motion. Part of that is also that, again, a lot of the fusions were bigger fusions, more destructive in the surgery. Whereas nowadays we do a less invasive, less destructive fusion for the most part for a similar type of case. So again, it's hard to compare apples to apples, but they're very similar surgeries. Now, reoperations, which is the real money question is, okay, so you've done this, if you did the artificial disc, have you decreased the amount of surgeries you're doing at adjacent levels, the other levels, which is what we're trying to avoid. The fusion causes more stress on the other levels, increases the chance of surgery at other levels. Does the artificial disc change that? Well, we haven't seen that yet. There's no good data, and all meta-analyses, I looked at 5 meta-analyses, big, looking at multiple studies over the last year that go back 10 years of data on this. No one's really shown decreased reoperation rates with the artificial disc compared to the fusion. And that's where the money was at. That was the whole reason why we were doing them 15 years ago. And so it's not to say there's not going to be. I mean, just because we haven't seen the difference doesn't mean it doesn't exist. And it may show up in 5 or 10 years from now. But we haven't really seen compelling evidence to say, oh yeah, we're saving these other levels. People aren't needing other surgery and therefore do more artificial disc. And that's why it's really shrinking in popularity consistently rather than growing, where we all thought it would be much bigger in this day and age. Now, one of the other things about this complications of the artificial discs is, as a surgeon, I've had some. I've had some patients who and I've had both. And this is the general rule if you talk to any surgeon. I've had some home runs. I did some artificial discs on people who went back and run a marathon, biking 100 miles a week. Great stories. Just never look back. It was an amazing. You got home runs. I'd say 50% of people, home runs, never look back. Outstanding. 30% happy they had it done. 10%, yeah, they're kind of happy, but it could be better. And 5 to 10% have issues. And that's just, and I may be optimistic because the data says it's even more people that are having issues. But that's been my experience. And I've seen fractures. I've seen broken vertebral bodies. I've seen posterior facet joints gapped open. Everybody has sunken in prostheses that come out the front. And these are a big deal. And I'll tell you, one of the main guys who does artificial discs all over the world, over in Europe, who's a good guy. He's an excellent surgeon. But I saw some of the patients coming back from Europe, because everything's better in Europe. That's the biggest line in America these days. Oh, in Europe, they're doing all this. Well, they don't have the FDA. They don't have as much control as we do here, which is, reassuring. But anyway, I saw some patients who came back from Europe and had like 3 artificial discs done, and then cement put into the vertebral body, screws put in the back, pedicle screws put in the back, and a dynamic type of system put in the back, which is crazy. I mean, that's so much surgery going on in this one spine, and it's so unrevisable. You start putting cement into the bone and putting in screws into cement, there's no going back. And so if somebody has a complication, what's next? But also what it told me is that was the revision surgery. So if you do an artificial disc, it doesn't work, then you may put some screws and cement in the back. Well, he was doing those the first time. What does that tell you as a surgeon? He was having enough complications with just the artificial disc. He started doing the revision surgery with the artificial disc the first time, which is concerning, to say the least. But he's an excellent surgeon and gets great results for the most part, but we all have complications. And the real question for me is, like I said, I have to live with these people for the rest of my life. I will not go to sleep at night. They will be with me forever. I need to know that what I'm doing on them I really think is best, is safe, and I know how to fix and I know how to treat issues if they're having issues afterwards. And so a fusion's a much more reliable black and white outcome of how to evaluate it. And then the last thing, so what's the niche of how I see it fitting into my practice? I still do artificial disc in the lumbar spine, despite everything I just told you, because it's still a good surgery. We still have issues with fusions, and we can fuse artificial disc in the lumbar spine. We can go in from the side. If it's at L4-5 or above, we can actually go in from the side through an X-lift lateral approach. We have computer guided to put screws in with big screws all over the body if we need to. So we have techniques to fix the artificial disc. That I had one patient come in who said he really wanted it, and I looked at his case and he fit. He was a perfect candidate for it. He had a degenerated disc at L5S1, really collapsed down, bone spurs, foraminal stenosis, nerves being pinched in the holes. And so I wanted to fuse that because I wanted to jack it open up the holes for the nerves, and he had facet joint arthritis. But then the disc above was moderately degenerated. It had some in-plate changes. It was a degenerated disc. It was dark. It had a bulge to it. And it was concerning enough that I thought if I fused L5S1, there's a good chance this guy's going to have pain from L4, L5. And so I don't want to fuse both and then put more stress onto L3-4, the one above. So I did the fusion at L5S1 from the front, standalone. And then at L4-5, I did an artificial disc to get rid of that painful disc and to put less stress on the level above. And his facet joints were normal at L4-5. And the disease process was early enough that I thought the artificial disc would hold up, but yet it was late enough that I thought it was indicated and it was necessary. And then I did another one like 2 weeks later. So artificial discs are still a good surgery. They have good biomechanics. They have good data, good outcome. They have not been shown to be worse than fusions. If anything, maybe a little bit better, but not really significantly enough to be adopted widespread. And that's why they haven't taken off like we thought they would have 15 years ago. So in summary, we talked about what are the reasons to do fusions or artificial disc replacements in the back. It's basically for discogenic pain if your back is killing you. And like I said, check out our Back Doctor app. Check out my other podcast called Avoid Pain. If you don't want to have any surgery, I recommend do all the rehab. But for 6 to 12 months, if you're in 8 out of 10 pain and you can't even live your life and your back is killing you and you can't work and you can't even do any kind of exercise, both of those surgeries are good, viable options that in general our results, people's pain goes from an 8 out of 10 to a 3 out of 10. Now, 3 out of 10 after surgery means that some are to 1, some are to 5. And then there's potential complications. The complications of both surgeries are less than 5% overall. Most of them are temporary and treatable, but they're real surgeries. We're going and taking those things out, moving blood vessels to the side. You can have all sorts of issues that obviously talk to your doctor before you make that decision. And they're both good surgeries. Fusions are more black and white. Artificial discs still have potential, and it's a reasonable option. Both of them are. It's really up to talking to your surgeon and figuring out what's best for you. If I can help in any way, please check out our webpage, watkinsspine.com, and check out our Back Doctor app. Thanks a lot. Have a good day. Bye.